Welcome to Test Stay Panic.
Glad to be here.
This is a highly concentrated, fast-paced review for your upcoming exam. We are, completely skipping the small talk today.
Yeah, strictly high-yield nursing interventions, critical safety alerts, and just really sharp definitions.
Exactly. Now listen, the content we are covering today is incredibly dense, so I'm going to speak slowly and clearly. I want you to listen closely, take a breath, and just focus.
It's all about methodically breaking it down so you actually retain it.
Right, so here's the game plan. We are doing a deep, methodical walkthrough of your critical source material first. We'll unpack the pathophysiology, the interventions, and the exact traps they will set for you on the test.
And then, right at the very end, we're going to run a rapid-fire top 5 recap of every single category.
Yep, just to really cement this knowledge into your brain before you walk into that exam room. So let's get right into our first critical emergency.
Sounds good. Let's start with burns.
Yeah, burns. One of the most devastating systemic injuries the human body can endure. This is not just a localized skin issue, right?
No, not at all. A major burn triggers this just catastrophic cascading effect across the entire body.
Let's look at the overall patient goals first. You are looking at wound healing, obviously.
Right, which means strict, sterile dressing changes, early physical therapy, and really aggressive nutrition.
And infection prevention, which is honestly your absolute #1 priority throughout all stages of care.
Have to manage their pain, too. Pain is highly subjective and must always be assessed.
Yeah. And finally, the ultimate goal is a return to pre-injury function, though, we have to acknowledge that this might be severely limited.
Yeah, by things like hypertrophic scarring or an amputation or even permanent organ damage.
So true. And the complications associated with burns are just severe and rapid.
Well, because the open damaged skin means the patient has completely lost their primary protective barrier against the outside world.
Right. So infection and systemic sepsis are massive, ever-present risks.
Then you have burn shock, which is actually a specific form of hypovolemic shock.
Oh, because the patient loses immense amounts of fluid through just pure evaporation off the open wounds, right?
No, exactly. Evaporation and through a process called third spacing. And you also need to watch very closely for cardiac dysrhythmias.
Wait, I want to make sure I understand the connection there. Why would a skin injury cause a heart rhythm issue?
Yeah, it's a great question. It comes down to cellular destruction and hyperkalemia.
Okay, walk me through that.
Think about the basic structure of a human cell. The vast majority of the body's potassium lives securely inside the cell, while sodium lives on the outside.
Right, the sodium-potassium pump.
Exactly. So when thermal energy from a burn destroys that cellular membrane, it literally pops the cell open. We call this cell lysis.
Wow, so all of that intracellular potassium just floods out.
It floods right into the extracellular space and enters the bloodstream. So suddenly, the heart is bathed in an incredibly high concentration of potassium.
Oh, and that alters its electrical conduction gradients.
You got it. Leading directly to lethal dysrhythmias like ventricular fibrillation.
That makes perfect sense. You destroy the walls, the potassium floods out, the heart gets overwhelmed.
Yep. You also have to monitor for organ damage from decreased cardiac output during that shock state.
And here is a critical high-yield complication for the exam. Rhabdomyolysis.
Especially with electrical burns.
Right. Let's trace the mechanism here. The muscle breakdown from the burn releases myoglobin.
Which are these massive, clunky muscle proteins.
Right. They get released into the bloodstream, which causes myoglobinuria, or muscle protein in the urine.
And when those massive proteins reach the kidneys, it's bad news. They literally clog the tiny renal tubules.
Oh, wow. So those tubules become ischemic and die.
Exactly. That's called acute tubular necrosis. And that directly causes an acute kidney injury.
Okay, so that's the complications. Now, for the exam, you must know your burn classifications cold.
Yes. Let's break them down by depth. First degree, also known as superficial.
This damages the epidermis only, right? Like a standard sunburn?
Yep. It's painful, it will become itchy, but it heals spontaneously in 3 to 5 days with absolutely no scarring.
The absolute crucial takeaway for your exam here is that first-degree burns are not included in your total body surface area fluid resuscitation calculation.
Never. Don't let them trick you with that.
Right. So second degree comes in 2 specific forms. Superficial partial thickness involves the epidermis plus the superficial dermal layers.
That usually blisters and heals in, what, 2 to 3 weeks?
Exactly. Then there is deep partial thickness, which destroys the entire epidermis and hits the much deeper dermal layers.
That takes 3 to 4 weeks to heal and often requires a skin graft.
And the healing time here is highly affected by how fast you resuscitate the patient with fluids, their nutritional status, and pre-existing conditions like diabetes.
Right. Then we reach the full thickness level, which encompasses third and fourth degree burns.
This destroys all epidermal and dermal layers,
Yeah.
right, going all the way down.
Down into the subcutaneous tissue, muscle, or even bone. It destroys the sweat glands and the hair follicles entirely.
The visual appearance can be white, red, brown, or leathery black, which we call Escher,
Crucially, a full-thickness burn will not blanch when you apply pressure.
because the capillary beds are completely destroyed.
Exactly.
And here is a massive safety alert for your exam regarding full-thickness burns.
Why?
There is absolutely no pain at the actual burn site
None at all. Why?
because the thermal injury has completely incinerated the nerve endings and sensory receptors in that tissue. But the surrounding tissue, which is likely suffering from second and first degree burns, that is incredibly painful.
Oh, severely painful. Never make the mistake of assuming your patient has zero pain just because their primary injury is a third-degree burn.
Right, they will require extensive pain management, and they will absolutely require a skin graft because that full-thickness skin cannot regenerate on its own.
Let's talk about the pathophysiology of a major burn. We have the local response, which includes that evaporative fluid loss.
And a highly increased risk of hyperthermia because the skin's thermoregulation ability is just gone.
Plus that massive infection risk we talked about. But the systemic response, which kicks in for major burns covering over 20% total body surface area, that is where things get highly complex and dangerous.
Right, systemic inflammatory response syndrome, or SIRIs, is activated across the entire body.
And this leads to massively increased vascular permeability.
Well, let's visualize that increased vascular permeability. The inflammatory mediators cause the endothelial cells lining your blood vessels to physically pull apart.
Yeah, let's unpack this using an analogy. Think of the blood vessels like the closed plumbing system in your house.
Okay, I like that.
A major systemic burn causes those pipes to become extremely leaky. The water or the intravascular fluid hasn't technically left the house yet. It is still inside the body.
But it's leaking out of the pipes and completely flooding and ruining the floor.
Exactly. And the floor represents your tissues. That fluid is now entirely useless to your circulation.
So you have evaporative loss, which is fluid leaving the body entirely, and third spacing, where the fluid is trapped uselessly in the tissues.
And that fluid shift has devastating consequences everywhere. In the lungs, the fluid leaks into the alveoli, causing pulmonary edema.
Which puts the patient at risk for ARDS,
Right.
acute respiratory distress syndrome, resulting in severely decreased gas exchange.
Renally, the profoundly decreased blood flow means a decreased urinary output.
And as we discussed, that myoglobinuria causes acute kidney injury.
The GI tract, completely starved of blood flow, can suffer a paralytic ileus or an increased risk of stress ulcers.
And metabolically, the patient enters a hypermetabolic state. The body is burning massive amounts of calories attempting to heal this trauma, leading to rapidly decreased muscle mass.
Which brings us to the mass required to treat this hypovolemia. The rule of nines for calculating total body surface area, or TBSA.
You have to be able to calculate this quickly. We are going to walk through this very clearly. The head and neck total 9%.
The arms are 9% each, meaning 4.5 for the anterior, 4.5 for the posterior.
The anterior trunk is 18%. The posterior trunk is 18%.
The legs are 18% each, 9 for the anterior and 9 for the posterior.
And the perineum is 1%.
So if your exam question gives you a patient with full thickness burns on the entire posterior trunk and the anterior of both arms, how do we calculate that?
Okay, let's do it. The posterior trunk is a flat 18%. The anterior of one arm is 4.5. The anterior of the other arm is 4.5.
So 18 plus 4.5 plus 4.5 equals 27% TBSA.
And that 27% plugs directly into the Parkland formula.
Which is the gold standard that dictates fluid resuscitation for the first 24 hours.
The formula is lactated ringers multiplied by 4 milliliters, multiplied by the patient's weight in kilograms, multiplied by the TBSA percentage.
Let's do the exact example from your notes to lock this in.
Okay, you have a 100-kilogram patient with a 27% TBSA burn.
You multiply 4 by 100, which gives you 400.
Then multiply 400 by 27.
Which means your total resuscitation volume for the first 24 hours is 10,800 milliliters of lactated ringers.
Now, the administration schedule is just as critical as the total number.
Right. You administer 1/2 of that total volume in the first 8 hours.
You give 1/4 in the second 8 hours, and you give the final quarter in the third 8 hours.
So for our 10,800 milliliter example, they receive 5,400 milliliters in the first 8 hours.
And listen carefully, because here is the trap they will set for you on the test. That first 8-hour fluid clock starts at the exact time of injury.
Not the time they roll through the hospital doors.
Exactly. If the fire happened at noon and they arrive at the emergency department at 2 p.m., 2 hours have already passed. You have to squeeze that entire first half of the fluids into the remaining 6 hours.
What is fascinating from a physiological standpoint is what happens in the second 24 hours of care.
The protocol shifts, right?
It does. You change from lactated ringers, which is a crystalloid, to colloids, like albumin.
Why do we strictly wait 24 hours to give albumin?
Because in the first 24 hours, as we discussed with the plumbing analogy, the capillaries are extremely leaky. Albumin is a massive protein molecule.
Oh, so if you give colloids early, those large protein molecules will slip right out of the leaky vessels and lodge into the tissues.
Exactly. And because water always follows protein through osmosis, that albumin will pull even more fluid out of the circulation and into the tissues.
Massively worsening the third spacing and the hypovolemic shock.
Yep. After about 24 hours, the initial inflammatory response lessens, the capillaries reseal themselves.
And now the colloids can safely stay inside the blood vessels, utilizing their oncotic pressure to pull that third space fluid back into the circulation where it belongs.
That brings us perfectly to the acute care, medications, and special cases for burns.
So, how do you know if your massive fluid resuscitation is actually working?
You are monitoring for a urinary output of 0.5 to 1 milliliter per kilogram per hour.
Which means they absolutely must have a Foley catheter placed immediately.
You want a mean arterial pressure, or MAP, greater than 65. You want a systolic blood pressure greater than 90.
And you want a heart rate decrease to less than 120 beats per minute.
Moving to medications, they require tetanus prophylaxis if their last shot was over 5 years ago, or if the burn is superficial partial thickness or deeper.
Because the protective barrier is gone.
Right. And for pain management, you must always pre-medicate 20 to 30 minutes before any painful procedure like debridement or hydrotherapy.
And here is a major safety alert regarding medication administration. The IV route is strictly preferred for acute pain management.
You must completely avoid intramuscular or IM injections during the initial burn shock phase.
Why is that?
Because peripheral perfusion to the muscles is incredibly poor during a shock seat, as the body shunts blood to the core.
Oh, so if you inject strong pain medication into the muscle, it just sits there unabsorbed.
Exactly. Later, when fluid resuscitation restores blood flow to those muscles, all those pulled IM doses will absorb at once.
Causing a lethal overdose. Wow. Always use the IV route.
For topical antimicrobials used in wound care, you need to know the specific functional differences.
Mafenide, also known as sulfamylon, is highly effective because it actually penetrates the thick Escher tissue within about 3 hours to fight underlying infection.
In contrast, silver sulfadazine and bezitracin do not penetrate Escher well at all.
And it goes without saying, always use strict sterile technique for these burn dressings.
Regarding skin grafting, if the patient receives an autograft, which is tissue harvested from their own unburned skin, you have to provide rigorous sterile care to both the newly grafted site and the donor site.
And the graft is held in place with gentle pressure only, right?
Right. If you apply too much pressure with tight dressings, you will cause decreased perfusion to the highly fragile new capillary beds.
And the graft will completely fail and die.
The overarching stages of burn care provide a timeline for your nursing interventions.
So the emergency stage begins at the onset of injury and lasts through initial fluid stabilization.
Focusing heavily on the ABCDEs, airway management, and the Parkland formula.
The acute stage becomes your primary nursing focus, usually occurring in the intensive care unit.
This covers meticulous wound care, surgical debridement, and grafting, while constantly monitoring for sepsis.
The rehabilitative stage focuses on physical therapy to maintain range of motion, the use of tight compression garments to actively minimize hypertrophic scarring, and intense psychosocial support.
Keep in mind, wound maturation can take up to 12 months, and the newly healing skin will be incredibly persistently itchy.
Let's talk about special burn categories. For chemical burns, your absolute first move before doing anything else is to check the material safety data sheet, the MSDS.
Because you need the exact, specific decontamination protocol for that chemical.
For smoke and inhalation injuries, you must be highly suspicious of internal airway damage. Carbon monoxide poisoning is a major silent threat here.
Yeah, carbon monoxide binds to hemoglobin with an affinity 200 times stronger than oxygen.
Literally starving the cells.
A classic late sign of this is cherry red skin, though it's not always present.
The treatment is non-negotiable. Administer 100% oxygen via a non-rebreather mask immediately to try and force the carbon monoxide off the hemoglobin.
And then we have electrical burns, which are notoriously deceptive.
The damage here follows the path of least resistance through the body's highly conductive tissues.
Specifically, the muscles, nerves, and blood vessels. They present with a distinct entry wound and an exit wound.
Meaning what you see on the outside of the skin is just the very tip of the iceberg.
The internal cellular destruction along that current's path is massive.
Because of that massive internal swelling inside the muscle fascia, you have to monitor electrical burns acutely for compartment syndrome.
You're also watching for the rhabdomyolysis we discussed earlier.
And sudden cardiac arrest from the electrical disruption to the heart.
Furthermore, the immense force of the electrical shock often violently throws the patient, causing a secondary fall trauma.
So you must always assess for cervical spine injuries.
We just talked about how burns destroy the skin, right? The body's ultimate physical shield.
So it makes logical sense that the absolute next thing we have to worry about is what happens when that shield completely fails and bacteria flood the system.
Let's talk about sepsis and septic shock, which is a quintessential medical emergency exemplar.
Sepsis is a deadly progression. It goes from sepsis to severe sepsis to septic shock to multi-organ dysfunction syndrome or MODS.
And ultimately results in death if the clinical team does not halt the progression.
Let's lock in the exact definitions and the criteria. It all starts with SIRS, Systemic Inflammatory Response Syndrome.
You need to know these 4 criteria, and we're going to explain why they happen.
A temperature greater than 100.9 degrees Fahrenheit or less than 97 degrees Fahrenheit.
A heart rate greater than 90 beats per minute.
A white blood cell count greater than 12,000.
And a systolic blood pressure less than 90 or a diastolic less than 70.
Let's look at the mechanism behind those SIRS vitals. The white blood cell count is elevated because the immune system is mounting an attack.
The temperature spikes as the body attempts to create an inhospitable environment for the pathogen.
Or it drops dangerously low if the body's compensatory mechanisms begin to fail.
The blood pressure drops because the massive systemic inflammation causes the blood vessels to severely dilate.
And because the blood pressure drops, the heart rate spikes reflexively.
Right, the heart beats faster in a desperate attempt to maintain cardiac output and perfuse the organs despite the widened floppy blood vessels.
Sepsis is defined simply as meeting those SIRS criteria plus having a known or strongly suspected infection.
Severe sepsis is sepsis plus the onset of organ dysfunction.
That organ damage happens directly because of malperfusion. The organs are not getting enough oxygenated blood.
Septic shock, the most critical stage, is severe sepsis complicated by profound hypotension that persists despite adequate fluid resuscitation.
Let's look closer at the pathophysiology of septic shock. The patient suffers from relative hypovolemia.
Unlike a bleeding trauma patient who has absolute hypovolemia, the septic patient still has blood in their body.
But the massive vasodilation, driven by an overproduction of nitric oxide, drastically increases the size of the vascular space.
You can think of it like a highway system. Normally, you have a 4-lane highway with enough cars or blood volume to fill it and keep traffic moving. Septic shock suddenly widens that highway to 20 lanes. You have the exact same number of cars, but now they are spread so incredibly thin that traffic pressure completely collapses.
Wow, that perfectly explains it. Add to that the increased capillary permeability, leaking fluid out of the vessels.
And the formation of microscopic blood clots, or microemboli, that block off the capillary beds.
The blood volume is severely maldistributed, meaning the cellular tissues are suffocating and starved of oxygen.
To combat this rapidly fatal cascade, we utilize the sepsis bundle,
which must be initiated strictly within 3 hours of symptom identification.
The bundle includes measuring the serum lactate level, which tells you how much anaerobic metabolism or cellular suffocation is happening.
You draw blood cultures ×2. You start broad-spectrum antibiotics.
You initiate rapid IV fluid resuscitation with crystalloids to fill that widened highway.
You start vasopressors if the hypotension persists after fluids. And you provide high-flow oxygen therapy.
Let's discuss the vasopressors. Norepinephrine, also known as Levophed, is your absolute first-line vasopressor.
It is an extremely potent alpha-1 agonist. It forces those wildly dilated floppy peripheral vessels to violently clamp down.
Squeezing the blood volume back toward the core organs to keep them alive.
Dobutamine can also be added for inotropic support to help the heart squeeze harder.
Here's where it gets really interesting, and this is an absolute non-negotiable rule for your exam.
Blood cultures must be drawn before the broad-spectrum antibiotics are given.
Right. If you give the antibiotics first, you immediately begin destroying the bacteria circulating in the blood sample.
When you send that tainted blood to the lab, they won't be able to grow the culture to tell you exactly what the specific infection is.
It is exactly like wiping away all the fingerprints at a crime scene before the detective even arrives.
Yeah.
You ruin the evidence.
Do not give the antibiotics until both sets of cultures are securely drawn.
Your nursing priorities here revolve heavily around treating the underlying cause, not just blindly treating the symptoms.
If the patient has infected IV lines or a heavily colonized Foley catheter, remove them if ordered.
Your hemodynamic goals are a MAP greater than 65 to ensure organ perfusion,
A urinary output greater than 0.5 milliliters per kilogram per hour to prove the kidneys are working.
and a central venous pressure, or CVP, between 8 and 12, showing adequate fluid volume.
You must also strictly monitor their blood glucose because the hypermetabolic stress response naturally causes severe hyperglycemia.
And remember, early recognition is the nurse's job. The patient is not going to ring the call bell and calmly tell you they feel septic.
You have to spot the trend in the vitals. So sepsis is a massive systemic infection. But now we need to pivot and look at infections and immune responses that specifically target the incredibly sensitive nervous system.
Let's dive into meningitis and Guillain-Barré syndrome.
Meningitis is the acute inflammation of the meninges, which are the protective membranes tightly covering the brain and the spinal cord.
You must clearly distinguish between bacterial and viral meningitis.
Bacterial meningitis is an absolute medical emergency. It is 100% fatal if left untreated.
It requires urgent, immediate IV antibiotics.
And the patient must be placed on strict droplet precautions for the first 24 hours of therapy.
Viral meningitis is generally less severe, usually self-limiting, and requires supportive care.
The signs and symptoms are classic, and you need to recognize them instantly. A severe, unrelenting headache.
Neutral rigidity, which is a profoundly stiff neck. Photophobia, or intense sensitivity to light.
You will also test for Kernig's sign, where straightening the leg causes severe back pain.
And Brudzinski's sign, where passively flexing the patient's neck causes their hips and knees to flexibly draw up.
The nursing care for meningitis focuses heavily on decreasing intracranial pressure, or ICP.
Keep the room dimly lit, maintain absolute quiet, and minimize all physical stimulation.
To definitively diagnose it, the physician will perform a lumbar puncture.
If it is bacterial meningitis, the cerebrospinal fluid will appear cloudy and purulent, packed with white blood cells and bacteria.
Medications include the targeted antibiotics, antivirals if suspected, potent diuretics like mannitol to rapidly reduce cerebral edema.
And anticonvulsants to prevent life-threatening seizures.
Now let's contrast that with Guillain-Barré syndrome, or GBS. This is not an active infection, but an immune-mediated destruction.
Following a viral infection, the patient's own immune system gets confused and begins attacking and destroying the myelin sheath.
Which is the insulating layer around the peripheral nerves.
The hallmark characteristic of GBS that you must memorize is rapidly progressing, flaccid, ascending symmetrical paralysis.
It begins with weakness and tingling in the toes and legs and steadily moves upward toward the core.
As the nerves lose their myelin insulation, the electrical signals fail and the patient completely loses their deep tendon reflexes.
The absolute life-threatening priority here. If that ascending paralysis creeps high enough to reach the diaphragm and the intercostal muscles, the patient loses the mechanical ability to breathe.
And goes into acute respiratory failure. You must perform continuous, meticulous respiratory checks, monitoring their forced vital capacity.
If we step back and connect this to the bigger picture, it is fascinating to compare the spatial constraints of these two neurological diseases.
Meningitis is deadly because the skull is a closed, rigid box.
Right, as the brain inflames and swells, there is physically nowhere for the pressure to go, leading to increased ICP and fatal brainstem herniation.
GBS, on the other hand, is deadly because of directional movement.
The paralysis relentlessly creeps upward until it physically shuts down the bellows of the lungs.
For GBS care, medical treatments include plasmapheresis, which is a procedure that physically filters the harmful, attacking antibodies out of the patient's plasma.
Alternatively, they may receive IV immune globulin, or IVIG, which essentially floods the system with healthy antibodies to block the harmful ones.
Also, because this was triggered by an immune response, these patients need to use extreme caution with any future immunizations.
Because vaccines can stimulate the immune system and trigger a devastating relapse.
That brings us from natural immune threats directly into the realm of weaponized, catastrophic pathogens.
Let's look at bioterrorism, specifically anthrax, botulism, and Ebola. Starting with anthrax.
It is caused by a spore-forming bacterium. It is absolutely not spread person to person.
So you only need standard precautions for the patient themselves.
It comes in cutaneous forms, causing necrotic skin ulcers, gastrointestinal forms, and inhalation forms, which is by far the deadliest.
Here is the crucial test fact for anthrax. To survive inhalation anthrax, the patient must begin a 60-day continuous course of antibiotics, usually ciprofloxacin or doxycycline, within 24 hours of exposure.
Listen to that wording carefully. Not within 24 hours of symptoms appearing, but within 24 hours of the known exposure.
If you wait for symptoms, the mortality rate skyrockets. Also, when decontaminating a patient covered in anthrax spores, you have to remove their clothing incredibly carefully.
If you rip the clothes off, you will aerosolize the fine powder into the air, creating an inhalation risk for yourself and the entire emergency department.
Next is botulism. This is also not spread person to person.
It is a neurotoxin that works by completely blocking the release of acetylcholine at the neuromuscular junction, effectively paralyzing the muscle.
Common sources include improperly home-canned goods where the anaerobic environment allows the toxin to thrive, or honey in infants.
Let me contrast this clearly with GBS so you don't mix them up on the test. Guillain-Barré is ascending paralysis moving from the feet up.
Botulism causes symmetrical descending paralysis. It moves from the head down.
The very first clinical signs are usually cranial nerve deficits, drooping eyelids, difficulty swallowing, and facial weakness.
But just like GBS, the massive lethal risk is when the descending paralysis eventually hits the diaphragm, causing respiratory failure.
Care for botulism requires the immediate administration of an equine-derived antitoxin.
This antitoxin binds to the circulating toxin and stops the progression of the paralysis, but it absolutely does not reverse the paralysis that has already occurred.
The paralyzed nerves have to slowly regenerate, so recovery takes a very long time, often months on a ventilator.
Also, because the antitoxin is derived from horse serum, there is a massive risk of severe anaphylaxis.
You must have epinephrine and diphenhydramine drawn up and immediately available at the bedside before you administer it.
Then we have Ebola, which is a viral hemorrhagic fever. Unlike anthrax and botulism, Ebola is highly contagious and is spread strictly by direct contact with infected body fluids.
It is not an airborne virus, but the fluid transmission is virulent.
The hallmark sign of late-stage Ebola is profound hemorrhage. The patient will be bleeding from multiple orifices from their IV sites, and you might see dark discoloration of the soft palate.
The isolation precautions here are extreme and unforgiving.
The patient requires strict droplet plus contact precautions, an N95 respirator, and they must be placed in a negative pressure room.
Doffing or removing the personal protective equipment is the most dangerous moment for the healthcare worker.
Doing it incorrectly is a massive self-contamination risk, requiring a trained observer to watch every step.
There are absolutely no visitors allowed under any circumstances.
And clinically, it is critical that you do not administer any anti-clotting medications to a patient whose vasculature is failing and who is already bleeding out from every orifice.
Let's shift gears from microscopic pathogens to massive kinetic physical trauma and how we sort the chaos when multiple patients arrive at once.
We are dealing with trauma and mass casualty triage.
Trauma broadly falls into blunt trauma, like a high-speed car crash where the deceleration forces crush and shear the internal organs without necessarily breaking the skin.
And penetrating trauma, like a gunshot or stab wound that directly pierces the tissue.
Pre-hospital emergency care focuses rigidly on securing the airway, controlling massive hemorrhage, and strict cervical spine immobilization.
Using a rigid backboard and the coordinated log roll technique. But when a disaster strikes and we transition to mass casualty incident triage, or MCI triage, out in the field, the entire philosophical paradigm of nursing completely shifts.
Right. The goal is no longer saving every single life.
The goal is doing the most good for the greatest number of people with severely limited resources.
Let's walk through the MCI color tags used in the field. Red means immediate life-saving intervention is required.
A patient is tagged red if their respiratory rate is greater than 30, their capillary refill is delayed greater than 2 seconds, indicating shock.
Or their mental status is so altered they cannot follow simple commands.
Yellow means delayed. They are seriously injured but stable enough to wait. Green means minor, often called the walking wounded.
And black means deceased or expectant.
If you open a pulseless patient's airway with a basic head tilt chin lift and they have no spontaneous respirations, they are tagged black.
I want to emphasize how this completely flips traditional nursing logic.
Inside a fully staffed hospital, you pour all of your resources, staff, and time into the absolute sickest, most critical patient.
But in an MCI field scenario, if someone is in cardiac arrest and not breathing, you do not initiate CPR.
It feels wrong, but if you spend 30 minutes doing CPR on one dying patient, 5 red tag patients who could have been saved with a simple tourniquet or airway adjustment will bleed to death.
You tag the pulseless patient black and you move on immediately.
Once those patients are transported inside the hospital doors, we abandon the colors and switch to the Emergency Severity Index, or ESI, for triage.
It is a scale from 1 to 5. ESI 1 requires immediate, all-hands-on-deck, life-saving intervention.
Think cardiac arrest or active massive hemorrhage. ESI 2 is a high-risk situation, often involving severe, unrelenting pain or acute disorientation.
Furthermore, if their vital signs show a heart rate greater than 100, a respiratory rate greater than 20, or an oxygen saturation less than 92%, it automatically bumps them up to ESI 2.
ESI 3 requires multiple different resources like labs and x-rays to diagnose.
ESI 4 requires few resources, like a simple laceration repair. And ESI 5 requires 0 resources, like a patient needing a prescription refill.
Inside the trauma bay, the team conducts the primary survey using the strict ABCDE framework.
Airway maintenance with simultaneous C-spine protection.
Breathing, ensuring the chest rises symmetrically and the trachea remains midline.
Circulation, checking the strong central, pulses the carotid or femoral first.
Disability, which means performing a rapid neurological check using the Glasgow Coma Scale.
And exposure, completely removing their clothes to find hidden injuries, but actively keeping them warm to prevent the trauma triad of death.
Crucially, if you find a life-threatening issue during the primary survey, like an obstructed airway or an arterial bleed, you stop and address it completely before moving on to the next letter.
After the primary life threats are stabilized, you initiate the secondary survey, using the FGHI framework.
You get a full set of vital signs. You focus on adjuncts like inserting a Foley catheter or an NG tube.
You facilitate family presence. You give comfort measures and pain control.
You obtain a detailed history and perform a meticulous head-to-toe assessment.
And finally, you inspect the posterior surfaces. You must log roll the patient to check their back, or you will miss a spinal injury or a penetrating wound.
When assessing specific blunt traumas during that secondary survey, watch closely for flank bruising in abdominal trauma.
This is called Gray-Turner's sign, and it strongly indicates a massive retroperitoneal bleed.
For severe musculoskeletal trauma, like a crushed leg, you must constantly watch out for compartment syndrome.
The massive swelling inside the rigid muscle fascia completely cuts off arterial circulation to the limb.
The hallmark, unmistakable sign, is pain that is completely out of proportion to the visible injury, unrelenting with pain meds.
Followed by extreme pallor and eventually a complete loss of the distal pulse. It is a surgical emergency requiring a fasciotomy.
Staying in the realm of environmental exposure, let's talk about the peripheral destruction caused by extreme cold, frostbite.
The classifications are frostnip, which is superficial and reversible.
Superficial frostbite, which damages deeper tissues and classically forms fluid-filled blisters at the 24-hour mark.
And deep frostbite, where the cellular death is so profound, the tissue turns hard, wooden, and black.
The clinical phases of frostbite injury are freezing, rewarming, the vascular phase where swelling peaks, and the late phase of tissue demarcation.
The treatment rules here are absolute and strictly tested. You must rewarm the frozen tissue using lukewarm water only.
The specific temperature range is 37 to 40 degrees Celsius.
You must never use excessively hot water or dry heat sources like a radiator because the tissue is completely numb and devitalized.
You will inflict severe thermal burns on top of the frostbite without the patient ever feeling it. And you must never, ever rub or massage the frozen area.
Why is rubbing so dangerous?
Because the water inside the cells has physically frozen into microscopic, jagged ice crystals. If you rub and massage that skin, those ice crystals act like thousands of tiny, razor-sharp knives.
You will literally shred the cells from the inside out, turning salvageable tissue into necrotic mush.
Precisely. And here is a highly counterintuitive rule.
Yeah.
You absolutely do not begin rewarming the tissue if there is any risk of it refreezing.
For example, if you're still out in the wilderness, a freeze-thaw-freeze cycle completely destroys all tissue viability.
It is actually better for the limb to remain frozen solid while you transport them to a definitive care setting than to thaw it out, restore blood flow, and let that fresh blood freeze again.
In the hospital, leave all blisters intact to prevent massive infection. Elevate the extremity to reduce the inevitable profound swelling.
And educate the patient that intense, throbbing, burning pain during the rewarming process is completely normal as the nerves wake up. Prepare to administer potent IV opioids.
Moving from peripheral tissue damage, we are now going to transition to the closed box of the skull. Let's talk about neurological emergencies, specifically increased intracranial pressure, or ICP, and traumatic brain injury.
The adult skull is a rigid, unforgiving bone box governed by the Monroe-Kelly doctrine. The skull holds three things: brain tissue, circulating blood, and cerebrospinal fluid.
Because the skull cannot expand, if the volume of one of those three components increases, the volume of the others must decrease or the pressure will rapidly skyrocket.
Normal ICP is 5 to 15 millimeters of mercury. Your cerebral perfusion pressure, or CPP, is the actual pressure pushing oxygenated blood into the brain tissue.
CPP equals your MAP minus your ICP. The clinical goal is a CPP greater than 60 to 70 to ensure the brain survives.
The clinical signs of severely increased ICP are critical to recognize immediately. Cushing's triad is a very late, highly ominous sign indicating imminent brainstem herniation.
The triad consists of severe systolic hypertension with a widening pulse pressure, profound bradycardia, and completely irregular respirations.
Let's explain why Cushing's triad happens. As the pressure inside the brain rises, it cuts off the blood supply.
The brain panics and activates a massive sympathetic response, severely constricting blood vessels systemically to force blood pressure up, trying to push blood back into the tight skull.
That causes the severe hypertension.
The baroreceptors in the carotid arteries sense this dangerously high blood pressure and trigger a vagal nerve response to slow the heart down, causing the bradycardia.
Meanwhile, the physical swelling is actively crushing the brainstem, which disrupts the respiratory center, causing the irregular breathing.
You must also watch the pupils very closely. A unilaterally dilated, unreactive pupil indicates uncal herniation, where the brain tissue is actively shifting and crushing the oculomotor nerve.
You must also monitor for pathological posturing. Decorticate posturing is when the patient's arms are rigidly flexed inward toward their core, indicating severe cortical damage.
Decerebrate posturing is when the arms and legs are rigidly extended straight out with the wrists rotated outward. Decerebrate indicates damage deep in the brainstem and carries a much worse clinical prognosis.
Let's differentiate the types of hematomas causing this pressure. An epidural hematoma is an arterial bleed, meaning it pumps fast under high pressure.
The classic, highly tested presentation is a traumatic impact with a brief loss of consciousness,
Followed by a lucid interval where the patient wakes up and seems completely fine.
followed by rapid, catastrophic neurological deterioration as the arterial blood rapidly fills the skull.
A subdural hematoma is a venous bleed, which oozes much slower, and the symptoms can take days or weeks to appear, especially in the elderly.
To decrease that lethal ICP, your nursing interventions must be highly specific. Elevate the head of the bed 30 to 45 degrees to promote natural venous drainage out of the head.
Enforce absolutely no Valsalva maneuvers, no straining for a bowel movement, no vigorous coughing, no bearing down.
Keep the room dim and minimize all physical stimulation. Maintain strict normothermia because a fever drastically increases the brain's metabolic oxygen demand, worsening the ischemia.
Osmotic therapy is your pharmacological weapon here. You administer medications like mannitol or 3% hypertonic saline.
These incredibly concentrated fluids circulate in the blood and use sheer osmotic pull to suck the excess fluid out of the swollen brain tissue and into the vasculature to be excreted.
If medical management fails, an external ventricular drain, or EVD, is surgically placed into the brain's ventricles.
It is the gold standard for continuously monitoring the pressure and actively draining off excess cerebrospinal fluid.
For a traumatic brain injury, or TBI, You have to understand the timeline of damage. You have the primary injury, which is the exact moment of physical impact, the blunt force.
There is nothing we can do to reverse that.
But then you have the secondary injury, which is the devastating swelling, hypoxia, and ischemia that follows in the hours and days afterward.
Comprehensive nursing care completely focuses on preventing and minimizing that secondary injury.
To trend their neurological status, you must know the Glasgow Coma Scale, or GCS. It is divided into 3 sections.
It scores eye-opening out of 4, verbal response out of 5, and motor response out of 6.
The maximum perfect score is 15. A score of 8 or below indicates a severe TBI, often summarized by the phrase less than 8, intubate.
Your absolute priorities for a TBI patient are your basic ABCs, but with much tighter parameters.
You must maintain an oxygen saturation strictly greater than 94% to prevent secondary hypoxic damage.
You must actively avoid any hypotension. A single episode of a systolic blood pressure dropping less than 90 is considered catastrophic for a severe TBI.
Because without pressure, you cannot perfuse the swollen brain. Implement strict seizure precautions, and aggressively control their temperature to prevent fever.
This raises an incredibly important physiological question regarding the ventilator settings. Why do we strictly maintain normal carbon dioxide levels, avoiding both hyperventilation and hypoventilation in a TBI?
Here is the mechanism. Carbon dioxide is a potent vasodilator in the brain.
If you hyperventilate the patient, blowing off too much CO2, it causes profound vasoconstriction in the cerebral arteries.
This vasoconstriction temporarily lowers the overall ICP because there is physically less blood volume taking up space inside the skull.
However, clamping down those arteries completely starves the already injured brain tissue of the oxygen it desperately needs to survive.
Therefore, deliberate hyperventilation is incredibly dangerous and is only used as a very brief temporary bridge to surgery during an acute active herniation event.
We are staying inside the brain for Section 9, but shifting from traumatic impact to spontaneous, life-threatening vascular ruptures, brain aneurysms.
A ruptured aneurysm causes a specific type of bleeding called a subarachnoid hemorrhage, or SAH.
The absolute defining hallmark sign of an SAH is the sudden onset of a thunderclap headache.
Patients who are conscious will consistently describe it as the absolute worst headache of their entire life.
There are 2 massive delayed complications you must constantly anticipate with a ruptured aneurysm.
The highest risk of a fatal rebleeding event occurs in the first 24 to 72 hours after the initial rupture because the blood clot attempting to seal the aneurysm is extremely unstable.
Then, the risk of cerebral vasospasm, where the irritated blood vessels spasm and clamp shut, causing an ischemic stroke, peaks 4 to 10 days post-rupture.
For diagnostics, you always start with a non-contrast CT scan of the head.
If the CT is negative but the clinical suspicion remains high, the physician will perform a lumbar puncture.
If the cerebrospinal fluid shows xanthochromia, which is a distinct yellow tint caused by the breakdown of old red blood cells, it definitively confirms a subarachnoid hemorrhage.
Care involves enforcing strict aneurysm precautions. The patient requires a quiet environment, strict bed rest, a dark room, absolutely no Valsalva maneuvers, and incredibly tight blood pressure parameters.
Let me use an analogy to explain why blood pressure control is paramount here. Think of the aneurysm like a stretched, fragile, weak spot on a bicycle tire tube that has finally popped.
Your body's clotting system has rushed in and put a tiny, incredibly fragile patch over the hole.
If you let the patient's blood pressure get too high, the sheer mechanical force of the blood will blow that fragile patch right off the artery, causing a massive, usually fatal, rebleed.
To prevent that delayed vasospasm complication we mentioned, you must administer a specific medication called nimodipine.
It is a calcium channel blocker that specifically targets cerebral blood vessels to keep them relaxed and open. It must be given exactly on time, every time.
Surgical interventions to secure the aneurysm permanently include a craniotomy to place a titanium clip directly across the base of the aneurysm.
Or a less invasive endovascular procedure that packs the aneurysm dome with tiny platinum coils to promote permanent clotting.
Moving from the brain, we descend down the central nervous system to Section 10, spinal cord emergencies.
The physical level of the spinal cord injury dictates the exact loss of motor and sensory function.
Injuries high in the cervical spine from C1 to C4 affect the phrenic nerve, which controls the diaphragm.
Meaning the patient will permanently lose the ability to breathe on their own and will be ventilator dependent.
Injuries lower down in the thoracic spine generally result in paraplegia, losing function of the legs but retaining use of the arms.
You must clearly differentiate between the two distinct types of shock that occur with spinal cord injuries.
Spinal shock is a temporary, localized neurological phenomenon where there is a complete loss of all reflexes and muscle tone strictly below the level of the injury immediately after the trauma.
Neurogenic shock, however, is a true life-threatening systemic hemodynamic emergency.
Let's explain why neurogenic shock happens. The spinal cord injury severs the communication pathway for the sympathetic nervous system.
Without that sympathetic tone constantly keeping the blood vessels slightly tight, you experience massive, uncontrolled systemic vasodilation.
The classic clinical triad for neurogenic shock is profound hypotension due to the vasodilation,
Profound bradycardia, because the sympathetic signal to speed up the heart is blocked, leaving the parasympathetic system unopposed.
and hypothermia, because the dilated peripheral vessels radiate all the body's heat away.
I want you to contrast this strongly with traditional hypovolemic shock.
If a patient is bleeding to death, they are hypotensive, but their heart rate is extremely tachycardic as the body compensates, and their skin is pale, cold, and clammy.
In neurogenic shock, they are hypotensive, but they are uniquely bradycardic, and their skin might be warm and flushed from the vasodilation.
Acute care for a fresh spinal cord injury requires rigid, strict immobilization to prevent severing the cord any further. You must always log roll the patient, keeping the spine in perfect alignment, requiring 3 or more trained staff members.
Hemodynamically, you aggressively maintain a MAP of 85 to 90.
You need a higher MAP than normal to aggressively force oxygenated blood into the damaged, swollen spinal cord tissue to salvage any surviving neurons.
And then we have autonomic dysreflexia. This is a massive life-threatening medical emergency specifically for patients who have an established spinal cord injury at the thoracic level T6 or above.
It occurs when a noxious, painful, or irritating stimulus occurs somewhere below the level of the injury. This unseen trigger provokes a massive, uncontrolled sympathetic nervous system response.
The clinical signs are dramatic and terrifying. The patient experiences sudden, explosive, severe hypertension with a systolic blood pressure rapidly shooting up to 200 or even 300 millimeters of mercury.
They will complain of a severe pounding headache and blurred vision from the pressure.
Above the level of the spinal cord injury, you will see bradycardia, profound flushing of the skin, and heavy sweating.
Below the level of the injury, you will see pale, cool skin and goosebumps.
Let's break down exactly why this bizarre bifurcated body response happens. The noxious stimulus, say, a severely distended bladder sends a desperate pain signal traveling up the spinal cord.
It hits the scar tissue roadblock at T6 and cannot reach the brain.
However, that blocked signal triggers massive, unchecked sympathetic vasoconstriction in all the blood vessels below the injury.
This intense squeezing violently forces all the blood volume upward, causing the systemic blood pressure to skyrocket.
The brain's baroreceptors sense this lethal, stroke-inducing blood pressure and attempt to slam on the brakes.
The brain sends parasympathetic signals down the vagus nerve to aggressively slow the heart rate, and it sends signals down the spinal cord to dilate the blood vessels.
But that dilate and slowdown signal cannot travel down past the T6 roadblock either.
So the upper body above the injury receives the signal. It becomes flushed, sweating, and the heart rate drops.
But the lower body, below the injury, remains completely clamped down in a state of massive vasoconstriction, driving the lethal hypertension.
Your nursing priority actions must be urgent and perfectly sequenced. Step 1. Sit the patient straight up immediately.
You are using gravity to orthostatically lower their dangerously high blood pressure away from their brain.
Step 2. Quickly loosen any tight clothing or constrictive binders.
Step 3. You must rapidly find and eliminate the noxious trigger. You check the Foley catheter first, because a kinked line or a massively full bladder is the most common cause.
If the bladder is empty, you check the bowels for a severe fecal impaction. Then you check the skin for pressure ulcers, ingrown toenails, or even a wrinkled bedsheet.
Crucially, you must find and remove the physical trigger before you start pushing strong antihypertensive medications. The medications will not solve the problem if the noxious stimulus is still down there screaming at the severed nervous system.
Okay.
Take a deep breath. We have methodically unpacked all systems. We have explored the pathophysiology, the why, and the how behind every major intervention.
Now, per our exam day protocol, we are initiating a lightning-fast run-through of the top 5 rapid review document. Listen very closely. This is your rapid recall checklist.
I am going to call out the category and prompt the point, and my expert here is going to rapid fire the exact facts you need to memorize. We are covering all 5 points for all 14 categories right now. Category 1, burns. What is point 1?
The Parkland formula fluid resuscitation clock starts exactly at the time of injury, never the time of hospital arrival.
Point 2.
First-degree burns are completely excluded from the TDSA calculation. And remember, third and fourth-degree burns have absolutely no pain at the actual burn site because the nerves are incinerated.
Point 3.
Infection is the overarching #1 risk. You must constantly watch for hyperkalemia from cell lysis and rhabdomyolysis from muscle breakdown clogging the kidneys.
Point 4.
Administer all acute pain meds via the IV route over the IM route due to poor absorption and shock. For wound care, Mafenid effectively penetrates thick Escher.
Point 5.
Electrical burns are deceptive. They have entry and exit wounds, massive hidden internal damage, and require an immediate C-spine clearance check.
Category 2. Anthrax. Point 1.
It is definitively not spread person to person. Survival requires 60 days of continuous antibiotic therapy.
Point 2.
Inhalation anthrax is by far the deadliest route of exposure.
Point 3.
Patient decontamination requires slow, careful clothing removal to avoid aerosolizing the deadly powder into the air.
Point 4.
You must initiate antibiotic treatment based on known exposure time. Do not wait for clinical symptoms to appear.
Point 5.
Rigorous patient education on strict 60-day medication compliance is absolutely essential to prevent relapse.
Category 3. Botulism. Point 1.
It causes asymmetrical descending paralysis. Paralysis of the diaphragm is the major life-threatening complication.
Point 2.
You must catch the early cranial nerve signs, specifically drooping eyelids and difficulty swallowing.
Point 3.
The equine-derived antitoxin S-DTOPS the progression, but doesn't reverse it. There's a massive anaphylaxis risk, so have epinephrine ready at the bedside.
Point 4.
Common ingestion sources include improperly home-canned food and giving honey to infants under 1 year old.
Point 5.
Expect a severely prolonged recovery period, lasting months to years as the nerve endings slowly regenerate.
Category 4. Ebola. Point 1.
It spreads strictly via infected body fluids. It requires full, impenetrable PPE, an N95 respirator, and isolation in a negative pressure room.
Point 2.
The hallmark late-stage clinical sign is profound hemorrhage from multiple sites.
Point 3.
Doe-offing, or taking off the PPE incorrectly, is the most massive self-contamination risk for the nurse.
Point 4.
Absolutely, NO anti-clotting medication should be given to these hemorrhaging patients.
Point 5.
Aggressive community contact tracing and strict hospital IPO vigilance regarding the patient's identity are critical public health measures.
Category 5. Trauma and triage. Point 1.
In an outdoor MCI scenario, a red tag means a respiratory rate greater than 30 or a cap refill greater than 2 seconds. A black tag means deceased or pulseless.
Point 2.
The in-hospital ESI system is a dynamic 1 to 5 scale based on acuity and resource needs.
Point 3.
The primary survey follows ABCDE. You must stop immediately to fix any life threats you find before moving on.
Point 4.
The secondary survey follows FGHI. You must log roll and inspect the posterior surfaces.
Point 5.
Compartment syndrome, marked by pain completely out of proportion to the injury, is a surgical emergency.
Category 6. Guillain-Barré syndrome. Point 1.
It causes ascending, symmetrical, flaccid paralysis. Reaching the diaphragm is the ultimate threat.
Point 2.
The disease course occurs in 3 distinct phases: acute, plateau, and recovery.
Point 3.
Medical treatments are plasmapheresis or IVIG. Tell patients to use extreme caution with future viral vaccines.
Point 4.
Continuous, meticulous respiratory capacity checks are your #1 nursing priority.
Point 5.
Being fully conscious while your body paralyzes is terrifying psychosocially for the patient. Provide intense support.
Category 7. Sepsis. Point 1.
You must fully implement the 3-hour sepsis bundle upon recognition.
Point 2.
Memorize the specific SIRS vital sign criteria. Understand the progression from severe sepsis to shock.
Point 3.
Norepinephrine is the absolute first-line vasopressor to clamp down those dilated vessels.
Point 4.
You must draw 2 sets of blood cultures before administering any broad-spectrum antibiotics.
Point 5.
Your overarching goal is to identify and treat the underlying infectious cause, not just mask the symptoms.
Category 8. Meningitis. Point 1.
Bacterial meningitis is 100% fatal if untreated. It is an immediate medical emergency requiring isolation.
Point 2.
Classic triad of signs: nuchal rigidity, a severe unyielding headache, and severe photophobia.
Point 3.
Implement strict environmental ICP reduction measures. Dim lights, absolute quiet.
Point 4.
A lumbar puncture diagnostic will clearly show cloudy, purulent CSF packed with white blood cells in bacterial cases.
Point 5.
You must give the prescribed IV antibiotics exactly on time to maintain therapeutic blood levels.
Category 9, frostbite.
Point 1. Rewarm the frozen tissue using lukewarm water only. You must never rub or massage the delicate tissue.
Point 2.
The injury progresses through 4 phases. Tell the patient intense burning pain during rewarming is expected and normal.
Point 3.
Differentiate superficial blistering frostbite versus deep, wooden necrotic frostbite.
Point 4.
Leave all fluid-filled blisters intact to prevent infection. Keep the extremity elevated to drain the swelling.
Point 5.
Always remember to assess for and treat systemic core hypothermia as well as the localized extremity damage.
Category 10, increased ICP. Point 1.
Cushing's, triad hypertension, bradycardia, irregular breathing is a very late ominous emergency sign of brain herniation.
Point 2.
Differentiate the bleeds. Epidural is arterial with a deceptive lucid interval, subdural is a slower venous bleed, and SAH presents with a thunderclap headache.
Point 3.
Interventions include elevating the HOB 30 to 45 degrees and ensuring absolutely no Valsalva straining maneuvers.
Point 4.
Administer osmotic diuretics like mannitol or 3% hypertonic saline to pull fluid out of the brain cells.
Point 5.
An EVD drain placed in the ventricles is the gold standard for monitoring and relieving pressure.
Category 11, TBI. Point 1.
Know the exact breakdown of the GCS scoring. I4, verbal 5, motor 6.
Point 2.
Intensive nursing care exclusively targets preventing the secondary ischemic injury cascade.
Point 3.
Defend the ABCs. Systemic hypoxia combined with hypotension equals a catastrophic, irreversible brain outcome.
Point 4.
Decorticate is inwardly flexed posturing. Decerebrate is outwardly extended posturing, indicating brainstem damage, which is significantly worse.
Point 5.
Treat any fever aggressively with antipyretics and cooling blankets to drastically reduce the brain's metabolic oxygen demand.
Category 12, brain aneurysm. Point 1.
A ruptured aneurysm causing an SAH presents with a sudden, devastating thunderclap headache.
Point 2.
Enforce strict aneurysm precautions. Keep the room completely quiet, totally dark, and maintain tight, low BP control to prevent blowing the clot.
Point 3.
To prevent the severe complication of vasospasm, give the calcium channel blocker nimodipine exactly on time.
Point 4.
Diagnostics begin with a CT scan first, followed by a lumbar puncture looking for yellow xanthochromia if the CT is negative.
Point 5.
Permanent surgical options are open craniotomy clipping versus less invasive endovascular coiling.
Category 13, autonomic dysreflexia. Point 1.
It occurs exclusively with spinal cord injuries at T6 or above. The blocked pain signal causes massive, uncontrolled systemic vasoconstriction below the injury.
Point 2.
Clinical signs include sudden, severe, stroke-level hypertension and a pounding headache.
Point 3.
Your absolute first action, step 1. Sit the patient straight up to orthostatically drop the blood pressure.
Point 4.
Rapidly hunt for the noxious trigger. Check the Foley catheter for kinks or clogs first.
Point 5.
You must successfully find and remove the physical trigger before pushing strong antihypertensive medications.
Category 14, the final category, SCI. Point 1.
The physical injury level equals the exact function lost. A high cervical injury at C1 to C4 requires a permanent ventilator.
Point 2.
Clearly differentiate the hemodynamic crisis of neurogenic shock, characterized by decreased BP and uniquely decreased HR, from the temporary reflex loss of spinal shock.
Point 3.
Immediately immobilize the cervical spine and strictly log roll the patient with multiple staff members.
Point 4.
Aggressively maintain a higher MAP of 85 to 90 to physically force oxygenated blood into the damaged cord.
Point 5.
Patients surviving with injuries at T6 and above carry a permanent, lifelong risk of autonomic dysreflexia episodes.
And that is time. We made it through the entire review. But before we sign off, I'm going to leave you with one final overarching thought about everything we just covered today.
Let's hear it.
I want you to think about the interconnected, relentless domino effect of the human body in crisis. It is almost never just one isolated, neat problem.
Oh, absolutely not. It's always a chain reaction.
Right. A simple thermal burn creates massively leaky capillaries, which directly leads to SIRS, which drastically drops the systemic blood pressure, which starves the gut of oxygen.
Which causes the gut barrier to die and leak bacteria into the blood.
Which causes overwhelming sepsis, which finally causes multi-organ dysfunction syndrome. Nursing isn't just about memorizing facts or treating a single symptom on a chart.
It is about clinically seeing those dominoes falling in real time.
Exactly. Understanding the exact mechanism mechanism of the next one in line and having the knowledge to throw your hand in the middle of them before they reach the end of the line.
That is the perfect way to frame the entire profession. You are the final line of defense, breaking that deadly chain reaction.
Take a deep breath. You know this material, you understand the pathophysiology, and you know exactly why we do these interventions. You've got this. Go crush that test.